Thank you all for coming for a great day of learning. We are starting the great debate. You know, what is better, a balloon pump or an Impella? And I hope at the end, we'll kind of come to a conclusion about which is actually better. You guys ready?
Impella.
Let's get ready to rumble.
Okay, so like Dr. Shreya, I really wish that we had financial disclosures, but we don't. But if someone wants to sponsor us, you know, you have my email. So our objectives is we'll be able to identify at least 3 differences of each device. And you know, our heart failure program is growing every day, so it's really important that we have these basics down. So before I go on an overview, everyone hold up their signs. Who do you think is better right now? Pick your sign. Impella, I see Impella, I see a balloon pump, I see balloon pump, I see a couple Impellas. Fantastic. So an overview of the balloon pump, just to kind of give you an idea of where these devices came from. The intra-aortic balloon pump was first used in 1968 by Dr. Kantowitz. Does anyone know what LT is famous for? Dr. Kantowitz. What else is he famous for? Does anyone know? We do it here many times a year. Yeah, who said heart transplant? Is that you too? It was Marisol? Okay, Marisol, you get a badge reel at the end.
Ooh.
So he wasn't the first person to do a heart transplant, but he was the first person to do it here in the US. Oh. He was the first person to do it here in the US. It was a pediatric patient, and the patient lived for, I think, only a couple hours, but the patient was, you know, very sick to begin with. So he's actually the one who kind of pioneered this idea, despite the fact that the idea was theorized a decade previously. They just didn't have the technology to actually perform it. So if you see in this picture A, that's what it first looked like. Back in 1968, it was as big as a refrigerator, so it's much different to the device that we see now. Balloon pumps use counterpulsation technology with a balloon that inflates and deflates to cause a different pressure gradient to offload that ventricle. And like I said, it's been 50 years of a device. It's considered a safe and very simple with low risk of complications. I know almost everyone here knows how to take care of a balloon pump. It's like old, reliable, I always say it is, versus its newer cousin. So as you can see here on like the slide, the balloon pump sits in the aorta, it deflates with that counterpulsation technology. It happens with synchrony of the heartbeat, so it works in together with the heart. And it's triggered by either EKG or fiber optic readings. It inflates during diastole, and it creates that pressure at the aortic root of about 70%. And then as the heart starts to have that isovolume contraction, like right before it really contracts, right before the aortic valve opens, the balloon will deflate. So timing is imperative. So as the heart contracts and the balloon deflates, it creates a pressure gradient. So it actually almost like pulls the blood out of that ventricle. So this helps decrease afterload because it almost creates like a vacuum. So that pressure is very low. And also just kind of helps pull that ventricle, as well as when the balloon inflates during diastole, you know, coronary arteries get the most blood supply during diastole. So you're hyper like oxygenating those coronary arteries, which is really important with your sick myocardium. So here's just like waveforms. Oh, look at that. So here's your waveforms on your balloon pump. This would be almost like a 2-to-1 augmentation. So as you see here is your unassisted aortic and diastolic pressure, and as the balloon inflates, the pressure actually drops much lower. So like I said, it really helps that afterload, decrease that afterload to help the heart pump more effectively. And as you hear, it's like another 2-to-1, so you can see the different pressure gradients between your diastolic augmentation and your assisted systole and your unassisted systole. So here's just another picture of kind of like what it looks like. It can be inserted via the femoral artery or the subclavian. We love the subclavian one because then our patients can ambulate. They're not bedridden, they're not uncomfortable, which is really nice. And of course, we've all kind of seen this tracing. The top is the EKG tracing. The middle is your balloon augmentation pressures, and the bottom is actually what the balloon is doing, inflating, deflating with those peaks and valleys. Just another summary. So the systole is the deflation. It decreases the afterload. It decreases the amount of oxygen that myocardium needs because, like I said, it creates that vacuum. So the heart doesn't need to push so much blood out, and actually helps pull some of that blood out to increase your ejection fraction. And that inflation during diastole perfuses those coronary arteries, especially that are either occluded or just got stented, or they have that ischemic injury from like a myocardial infarction. The most common uses of a balloon pump is refractory angina, so like occluded stents or partially occluded stents, cardiogenic shock. Sometimes the heart needs a little help after surgery, after it's been damaged. So cardiac failure after surgery, if it just needs that little extra support. Ventricular support during and after high-risk PCI. So I know sometimes the cath lab will implant these devices during stenting, and then either leave them in if that's what the patient needs, or take them out if the pressures improve. As a bridge to transplant, we have a lot of heart failure patients, especially on C8, that are just kind of waiting for their heart. They're too sick to go home. So having a balloon pump really helps optimize their recovery because they can stay mobile. They feel a little bit better, so they're able to keep their standard of care high. They can feel better, they can walk, they don't decompensate as fast if they have a balloon pump. We can use it in cardiogenic shock and also acute decompensated heart failure that hasn't progressed to shock yet.
All right, so now we have the Impella. Here's a picture of the Impella catheter in the left ventricle supporting the left side of the heart. In this next slide here, we have the whole Impella setup. So you have the catheter, which is in the heart. It is connected to the cable that attaches to the controller, and the purge fluid that is flowing to the sidearm to get to the catheter to prevent clotting. So we have the types of Impellas. The Impella devices are catheter-based devices that provide hemodynamic support while allowing the heart to rest. The types of Impella catheters are the Impella CP, the Impella 5.5, which both support the left side of the heart, and the Impella RP, which supports the right side of the heart. The Impella CP and 5.5 can be inserted percutaneously through the femoral or axillary artery, or surgically through the axillary artery or aorta. And the Impella RP can be inserted percutaneously through the femoral vein. Here we have the Impella CP with Smart Assist. It's a heart pump that's approved for use in high-risk percutaneous coronary intervention and cardiogenic shock. Here, if you look at the picture, we have the blood inlet area where the blood is drawn into the cannula, the outlet area where the blood exits the cannula into the aorta, and the optical sensor, which assists in positioning, managing, and weaning the Impella heart pump. When the Impella device is properly positioned, it pulls from the blood from the left ventricle through the aortic valve and into the root of the ascending aorta. This flow reduces ventricular and diastolic volume and pressure and increases the mean aortic pressure and flow. And here's a slide with the p-values. So with the p-values, you can adjust, it's called performance level, and then you can adjust the flow, which also, you get a higher cardiac output. The more revolutions per minute, the higher the flow you would get. With the CP, the highest flow you can get is 3.5, 3.7. Right, here we have the Impella 5.5 with Smart Assist. It's a minimally invasive surgical heart pump that provides full cardiac support with maximum unloading, allowing the heart to rest and recover. It unloads the left ventricle, reduces ventricular work, and provides the circulatory support necessary to allow recovery and early assessment of residual myocardial function. Similar to the CP, the Impella 5.5 has an inlet, outlet, and optical sensor. The difference between the two is the 5.5 doesn't have that pigtail at the end of the catheter, keeping it in place. It moves blood in the same way as well. So it pulls the blood from the ventricle through the aortic valve and into the root of the ascending aorta. And since the blood is moving through in the same direction as a CP, the flow still reduces ventricular and diastolic volume and pressure and increases the mean aortic pressure and flow. Next slide. All right, and here's just a closer image of the 5.5 in the left ventricle. If you see, it's placed with the inlet past the aortic valve and the outlet in the ascending aorta so that the blood will move from the left ventricle into the aorta. And here's another image of the 5.5 with the catheter and the cable. So the cannula sits in the heart. The blue suture hub is attached at the suture at the insertion site on the outside of the body. The sterile sleeve lock locks the catheter from moving. When it's unlocked, the physician or advanced provider can adjust the placement of the Impella at the bedside and within the sterile sleeve. All right, next type of catheter is the Impella RP with Smart Assist. It's a single vascular access pump designed for right heart support. The Impella RP with Smart Assist is inserted percutaneously through the femoral vein and into the pulmonary artery, with the inlet sitting in the IVC and the outlet in the PA. It enables biventricular support when the left side is supported with the left-sided Impella. It still has an inlet where the blood is drawn into the cannula, and that's sitting in the inferior vena cava at or below the level of the diaphragm. Your outlet area is where the blood exits the cannula. And then the dual sensor, it has a dual sensor where, it's comprised of the differential pressure sensor and optical pressure sensor. So these assist in positioning, managing, and weaning of the Impella heart pump. And when it's properly positioned, it pumps blood from the inferior vena cava into the pulmonary artery. This flow reduces ventricular workload, decreases central venous pressure, and increases overall blood flow into the left heart. All right, and here's just an image of it inside the heart. All right, another part of the Impella catheter is or Impella device is the automated Impella controller. This is what your Impella catheter is attached to by the cable. It provides insight into the catheter function at a glance. It's an interface for monitoring and controlling the Impella heart pumps. It provides real-time operating data. It also delivers purge fluid to the Impella devices. The purge fluid is used to prevent clotting in the cannula, and it also provides backup power. So when it's fully charged, it can operate on its battery for at least 60 minutes. Here's an image of the automated Impella controller for the Impella CP in 5.5. The red line here is the aortic waveform. The white line is the left ventricle pressure, and the green is your motor current. And on the bottom of the screen there, it shows your Impella flow, current, purge flow, and purge pressure, cardiac output, and cardiac power output. And then with the Smart Assist, it calculates the cardiac output and cardiac power output to aid in measuring end organ perfusion. This is an image of the controller screen for the Impella RP. So here it displays the pulmonary artery waveform shown as the yellow line, the central venous placement signal, which is shown in blue, and below it is the motor current waveform in green. It also shows a calculated PAPI score. It also shows on the bottom of the screen, as well as the as seen with the CP in 5.5, shows your Impella flow and also the purge system. All right, so I've been saying Smart Assist like after every Impella, so they have something called Smart Assist. It's a cloud-based program for the Impella. It simplifies the setup of the Impella device. It allows for remote monitoring for better patient outcomes. So if advanced practitioners at home and they want to check on their patient and see how they're doing, they're able to log in and see, the numbers and what's going on with the device at the time. It's also good for if you're having issues with your pump as well. So the Impella rep can log in, look and see what's happening. If you're having like suction alarms, they can help you troubleshoot. It also has new sensor technology on the cannula. So all those dual sensors, optical sensors, they allow for better repositioning and real-time advanced and intelligent metrics. And these metrics can help us show weaning trends of left ventricular end diastolic pressure and MAP, which assists in hemodynamic assessment and successful weaning. You'll have better and faster resolution of suction alarms and earlier identification of right heart failure. And as I said before, it also helps display and calculate the cardiac power output.
Okay, here's a checkpoint. Hold up your signs. What are we feeling now that you have an overview of both devices? Okay, I see Impella and see Impella. Thank you, Grace. We have a balloon pump lover over here.
I know we get a lot of Impella.
Yes, Jody, balloon pumps. Woo. Yes, Maria, balloon pumps. Okay, so now we're going to talk about the advantages and disadvantages of kind of both. So first, the advantages of the balloon pump, like I said, old, reliable, 50 years of research and data with, more usage, more improvement. We don't need, 5 different devices doing different things. We just have one good balloon pump we all know how to use. Over 50,000 balloon pumps are inserted annually. So it's something that hospitals are comfortable using. It's nurses are comfortable taking care of these patients. And it's really a more well-known, well-utilized device with like breast, different complications. 50,000 is a lot. I couldn't find a direct number of how many Impellas are inserted, but only 1,000 hospitals in the US implant Impellas, which you think is 1,000 is a lot, but in reality, there's only 1,000 hospitals in just New England. So there's a whole other country of hospitals that, don't necessarily use Impellas. It's a really small catheter. It's only 7 to 8 French cannula, and it can be inserted at the bedside. Or if they go to cath lab, it can be inserted axillary, in which the patient can then ambulate. It's a preferred method in multi-vessel coronary artery disease due to that increased coronary artery perfusion. And due to that, it also decreases afterload because it gives that myocardium extra oxygenation. And like I said, using that vacuum technology with that counterpulsation pump, it kind of pulls that blood off the ventricle. It works within the cardiac cycle rather than independent of it. So, we really have to have, I know you have to have a native heart function, but it kind of just helps that heart recover because it works with it instead of just independently. It decreases the workload, which may allow for a lower dose of inotropes. Inotropes are great, we use them, but they don't come without risk. They can cause tachyarrhythmias, myocardial ischemia, can cause hypotension and tissue necrosis in those fragile capillary beds, like the periphery and for example, like the kidneys. It benefits patients with severe LV failure. I'll go into it a little bit later, why the Impella is not so good with severe LV failure. There are new studies going on that we can actually use balloon pumps without anticoagulation. The studies are not yet published, but they're in the works right now, and they're showing promising data. I just don't have the numbers yet. That if a balloon pump is on 1-to-1, they don't necessarily need anticoagulation. It's different when we start to wean them, but for now, like I said, the studies are there. It's also a low cost option, and a balloon pump only costs between $800 to $1,200 for the device and the insertion, which sounds like a lot, but you'd be surprised how expensive other devices are.
All right, so here we have the advantages of Impella, just kind of going through like how it works. So the blood's going to move continuously from the left ventricle to the ascending aorta, as I said. So this directly unloads the blood from the left ventricle, decreasing end diastolic pressure and volume, subsequently increasing the aortic pressure and the flow. You will have decreased oxygen demand and increased oxygen supply, and thus increased systemic hemodynamic support. Cardiac power output is measured in watts, and it's formulated using the cardiac output and mean aortic pressure. A cardiac power output less than 0.6 watts is indicative of a hemodynamic compromise and associated with increased mortality. All right, so some advantages of Impella. These first few advantages I explained in the previous slide. So when we go into the efficacy of the Impella is independent of rhythm, whereas with the balloon pump, the balloon is trying to inflate and deflate to each heartbeat. So if you're in tachycardia, it's gonna be difficult, or AFib. There are different ways to insert the Impella, either percutaneously or surgical. It's a small cannula size as compared to VA ECMO.
Mine's smaller.
You can do bedside position adjustment with that sterile sleeve lock.
So you can do that with a balloon pump too.
The automated Impella controller is easy to read and use, and it has a smart assist which displays and calculates various hemodynamic metrics, which balloon pump, I believe they don't have those.
Not yet.
There's a reduction of mortality. It's cost effective in the long run, as with, with reduced length of stay and reduced readmissions, which I will speak more of in the next slides.
So the device itself is not cost effective, but maybe its after effects will be.
Yeah, the afterwards. Maybe not upfront, but the after costs. All right. So here we have a it's showing Impella is associated with reduced mortality and costs. Studies show the use of the Impella is particularly cost effective with a 29 to 47% reduction in adverse events at 90 days. So that's your death, stroke, MI, and or repeated revascularization. There's also a 58% reduction in 30-day mortality for patients with CAD. And also there's a 44% lower in-hospital mortality for patients with higher comorbidities versus the balloon pump.
I just want to point out though this graph looks like that Impella is better, I would also just want you to take a look at the sample size. Impella only has about 4,500 in their sample size versus balloon pumps has almost 17,000. So that's almost quadruple the data. So this uneven sample size can affect the statistical power of the study, and it introduces kind of bias. And it makes the evidence less precise. So yeah, the dark blue is the PVAD or the Impella as we're using it, and then the light blue is the Impella. So I just want to show you that 17,000 sample study versus 4,500. So you know, these graphs look a little biased.
Listen, we're the new kid on the block. We just had FDA approval in 2015, so we're getting up there. I mean, you've had what?
50
40
years,
60 years to come up with data. All right, and here we have what was it, the cost effectiveness of it, just showing reduced length of stay for patients with the Impella, and also fewer readmissions as well.
Okay, this graph is a little bit better because the sample sizes both are around 200, but this one I'm a little suspicious. Okay, so we're going to talk about the disadvantages of both.
All right, so here we both have our disadvantages are limb ischemia, thrombocytopenia, bleeding, infection at the insertion sites, immobilization from where the device is placed, probably in the femoral artery, which would cause the patients to have to be almost supine in bed, and device malfunction. As
in most things we do, we really have to weigh like the risk versus the benefits, because these devices are great, but they're not without fault.
All right, so some disadvantages of the balloon pump. You can have dissection of your aortoiliac access. That's if the balloon pump is placed femorally. You can also have intravascular thrombus. Complications are higher for women, patients with PVD and diabetes. And then obviously if a patient has all of these things, and they're at the highest risk for complications. Also, the longer duration of the balloon pump support, you have increased risk for complications such as septic and thrombotic emboli. And you can also have end up developing claudication or nerve paresis if you're having vascular issues as well. The poor quality EKG and cardiac arrhythmias may lead to inaccurately timed balloon pumping.
Poor quality.
Not only negating the hemodynamic benefits, but also increasing LV workload as a myocardium contracts against the inflated balloon. Balloon inflation in the presence of aortic regurg increases left ventricular end diastolic volume and pressure, inducing further ischemia. It's like, the whole thing we're trying to prevent. Balloon rupture, it may cause air embolism that could lead to neurological injury. As we had said, the proper device positioning is important. You could close off blood flow to any lower limb, or any visceral perfusion may be poor. And also the balloon pump doesn't support the RV.
So it actually indirectly supports the RV by perfusing those coronaries. And the right coronary actually doesn't get as much blood flow as the left due to that pressure gradient. The left kind of sucks it all up, especially because it's a bigger part of the myocardium. So although it doesn't directly offload the RV, it does, help it by giving it the oxygen that it needs to pump.
Listen, we have a whole device for it though. All right, and then in this landmark study, the intra-aortic balloon pump shock 2 trial, it ended up showing that the intra-aortic balloon pump has no effect on all-cause mortality at a 6-year long-term follow-up. Mortality is still very high with cardiogenic despite contemporary treatment with revascularization therapy.
Okay, now I get to fight for my balloon pump. Here are the disadvantages of the
Fight for your life.
Okay, although the Impella might be designed to provide a more powerful and sustained direct circulatory support, patients with severe LV dysfunction actually have an increased afterload caused by the axial flow of the mechanism of action of this Impella. So the direct blood flow from the ventricle to the aortic causes a high aortic pressure, which actually can increase afterload on those patients with severe weakened LVs. Due to its placement, and it can also cause mechanical trauma to the aortic valve. You know, if these patients are already having issues, a leaky aortic valve is not something that you want when the device is removed. And like I said, Impella's only got, you know, the 2.5 was only approved in 2008, and the 5 was
2015.
approved in 2015. So I don't know if it, you know, works yet.
We're new,
We're new.
advanced. The future.
And although Brielle mentioned that it might cause readmissions or decreased lengths of stay, I just want to put it out there that the Impella can cost anywhere between $10,000 to $40,000. The 2.5, which we don't really use anymore, is $22,000. So that's very expensive. The balloon pump, like I said, it's only like $800 to $1,200. You know, it's a cheaper
Listen, we're
alternative.
gonna pay for it in the afterwards, though. When patients are readmitted, when they're coming in back with complications.
Also, the FDA only approved the Impella for 6 hours. So anything after 6 hours is, you know, off-label use, just saying. Like I said, there's a limited availability of Impellas or facilities implanting Impellas, and you need that specialized training. It needs anticoagulation. That purge fluid always comes heparinized as well as systemic heparin. There's a higher risk of vascular injury. Just like I said, you need a bigger sheath, or it has to be surgically implanted, which can cause trauma to that spot. And there's a higher a risk of stroke. In multiple studies, the Impella is around 5 to 7% incidence of stroke, where balloon pumps are only around 1 to 2. Okay, checkpoint. Where are we feeling? Okay.
Ooh.
Okay, we'll let
All right,
everybody.
yeah, let's see. I
All
see a
right.
lot more balloon pumps
I see
right
a lot
now.
more
I see a
balloon
lot more balloon
pumps,
pumps,
yes.
but Impella is still hanging strong.
Okay, are you guys, are you guys ready? There's actually inconclusive results. So there's a landmark PROTECT 2 trial, which did not show statistically significant difference in 30-day all-cause mortality with either balloon pumps or Impellas. They're currently doing the PROTECT 4 trial, and that's ongoing. So we'll kind of see, where it, projects us into the future. And then there's an article by Feely et al. That is the largest historical cohort that investigates the hemodynamic benefits of Impella versus balloon pump in patients with myocardial infarction complicated by cardiogenic shock. Despite the fact all we do, these patients are so sick. So like there's going to be a 40 to 75% chance of mortality no matter what we do. But this study was 700 patients from 48 hospitals from 9 different countries that showed, again, there's no difference between the 30-day all-cause mortality between the two groups. And like I said, each device has their benefits and their downfalls within this. So the Impella had a higher risk of vascular complications such as bleeding, but the balloon pump had a higher risk of limb ischemia. So, you pick your battles. As these graphs kind of show, the black is the balloon pump and the blue is the Impella. Although the Impella might start off better right out of the gate with decreasing serum lactate, improving ejection fractions and such, if you see, they both end up at the same. So, balloon pump slow and steady wins the race. Impella, they might start off faster in the gate, but they cross the finish line at the same time.
All right, so there's multiple factors to be considered when determining the mechanical circulatory device you're looking for, such as the device itself, hemodynamic impact, disease severity, situation urgency, available access sites, coexisting mechanical supports, structural abnormalities, and institutional factors. In mild hemodynamic instability or emergent situations, balloon pump is often considered in view of its low cost, ease of insertion, and operator familiarity. Concomitant pharmacological support is often necessary and may be adequate for temporary support, and centers with experience may prefer the similarly low profile Impella 2.5 CP, which is inserted just as quickly and provides superior hemodynamic support compared to the balloon pump. The anticipated duration of support, anatomical variations, and exit strategy are also factors that need to be considered.
And the winner is, can we get a drum roll? You guys ready? Hold up your signs. It's you guys.
Yay.
These devices have their benefits and their cons, but you know, they're just pieces of metal without the hardworking nurses at the bedside, really caring for these patients, monitoring for those complications and managing those patients so they can get home. So, you know, it's not, there's no device without you guys. So, woo! Does anyone have any questions? Does anyone, you know, sway? They thought balloon pump was better, now they're on Impella? No?
No.
Stubborn groups of folks.
Yeah, they know. All right, thank
Thank you all.